It is lovely to see you all here today to celebrate this fantastic event. I do love inaugural lectures. So we've got the extended Lovat family here in the second row, so a very warm welcome to you. We have a number of esteemed professors, too many to count tonight. Thank you all for coming. We've got collaborators, we've got friends, we've got students. We have patients here tonight. A particularly warm welcome to patients who've decided to come tonight and celebrate this fantastic event. So tonight we're going to hear, I don't know what we're going to hear about actually, but it's going to be quite a ride, so you're going to have to fasten your seatbelts. I've had kind of warnings already. But this is a particular pleasure for me, because Laurence and I are very much alike. We both started our kind of academic clinician scientist careers in the National Medical Data Centre. We are both interested in diagnostics. We're both interested in identifying and treating pre-disease, and I'm sure we'll hear about that today. But it's a particular pleasure because Laurence was the first professor I congratulated when I was director of the Division of Surgery. So it was him that I first said, "Congratulations, Professor Lovat." And it was one of the wonderful moments and one of the great joys and privilege of being a director is to convey the information from the promotions round to the individual who had been waiting some 7 or 8 months to find out the news. And I remember that day vividly. And this is a celebration of that. This is a celebration of everything that went up to that. And we've been waiting a long time for it, but the moment has arrived. So once again, Professor Lovat, many, many congratulations. We look forward to hearing the story.
Thank you very much, Professor Emberton. That actually reminds me that when you phoned me, I don't know if you remember this, but when you phoned me to tell me that I'd been made professor, I was actually sitting in the jury room about to convict. In fact, we didn't convict in the end. I was in such a good mood. Anyway, a felon. A brighter future for esophageal cancer. Before I tell you a little bit about what I've been doing for the last 20-odd years, I would like to make a few thank yous. And there are quite a few people I would like to thank. And I'd like to start by thanking, if he can, my grandparents. This is a picture of my grandparents on their wedding day in the late 1920s, my father's father and mother. It was my father's father who looked at me when I was a baby and said, "This one will be a professor." I would also like to pay tribute to my parents, to my late mother, who sadly passed away between the time that I applied for a professorship and received it. She never actually had the pleasure in life to actually see that I'd made it. And to my father, who's still alive, but sadly so unwell these days that he's not able to be here with us. But I owe to my parents a great debt of gratitude for helping me to get to where I am today. And above and beyond all those thanks, there's one person that I really have to thank, and that is the girl of my dreams, the girl I married 25 years ago, who has given up more for me than anybody could imagine and who supported me all the way through. Thank you so much to Linda. And Linda, I say to you, what's mine is yours. In more ways than one, not only my work, but also our 6 children. And in case anybody is confused, Ardina is not married to Aaron. In fact, Ardina is married to Shaul, and Aaron is married to Rachalea, and we're delighted to have you all here with us today. Actually, not everybody is here with us today. Zach, our baby, there he is away with school, and so I asked him just to say something.
You only became a professor because you both people around.
Okay, so you'll see that there are little keypads. I couldn't be sure that you'd be able to use a keypad, so we're going to start with something very simple. What you do is, if you're happy to be here, you press 1, and if you're not happy to be here, you press 2, but don't do it yet. You have to wait. I'm going to press the little green button, and then you have 15 seconds. Okay, the 15 seconds starts now, and you can see the clock counting down. Press only 1 button, please, 1 or 2. Okay, Sammy, press 1. And we're going to see the answers very, very soon. Do come in, whoever you are. And I'm... Okay. Thank you to those people. So let's move on to something slightly more interesting. If I can get this thing to work. Sorry, I did test it, he said. Oh dear, it's not working at all now. Oh, hang on, here we are. No, hang on. Right, question 2. Professor Lovat has some unusual qualifications. BSc Hons, I have an honorary, what do I have? I have a Bachelor of Science. I have an MBBS, Bachelor of Medicine, Bachelor of Surgery. PhD, you know what that is. FRCP, Fellowship with the Royal College of Physicians. I also have a Diploma in Management. And I also have the ITEC qualification. Is ITEC A, or number 1, Information Technology Examination Certificate? Number 2, Internal Medicine and Therapy Examination Certificate. Number 3, International Therapeutic Examination Council Massage Therapist. Or number 4, International Triathlon and Extreme Sports Coach. Okay, and you have got 15 seconds starting now. Go for it. Is it 1, 2, 3, or 4? So I've written them A to D, but this is just to confuse you. It's 1, 2, 3, or 4. Okay, let's see how good you are with your qualifications. Okay, 1, 2, 3, or 4. 1 second left. And, oh look. And the correct answer, ladies and gentlemen, is actually this one. International Therapy Examination Council. I am a qualified masseur. And if anybody wants to know how I use this in internal medicine, I did so actually many years ago. So, hang on a minute. Oh dear, what's going on? I'll get there. My challenge today. So the challenge is actually slightly complex today, and you'll see why. Which description do you think fits you best? You're allowed to choose up to 3 things. Okay? Are you, number 1, a scientist? Number 2, a doctor? Number 3, paramedical, nursing, administrator, other supporting role. Number 4, a member of the public. Or number 5. Okay? Do come in. Come and join us. Come and join us. Don't stand outside. You'll be there all day. Okay. So, okay, you've got 15 seconds. You can press up to 3 buttons this time. I promise I will teach you something in a minute. Okay, so this is my problem. My problem is that although there are quite a lot of people who are scientifically qualified, and there are quite a lot of doctors in the room, we also have a whole load of people here who know nothing about either science or medicine, and I'm supposed to explain to you what I've done in the last 20 years, and this is going to be a little bit of a challenge for me. So for those of you who are, and by the way, I should tell you, there are about 30 or 40 people all watching online. Hello, wherever you are in the world. People from America all the way across to the east. I don't know where, Costa Rica actually, yeah. Where's Costa Rica? Sorry, Steve. So anyway, we do have people from all over the place, and I want to make sure that everybody has an opportunity to understand what's going on. So, some of the slides will contain graphic images. Some of the work does involve experimentation with animals, and all the work has been undertaken with careful consideration what we call the 3 R's, replacement, reduction, refinement, and that is to minimize the use of animals in medical experimentation. It's only going to be a small part of the lecture, but I just thought I'd say that up front. So I'd like to start my story 20 years ago when I did my PhD at the Royal Postgraduate Medical School at Hammersmith Hospital, now part of Imperial College, under Professor Mark Pepys, FRS, and Mark sends his apologies, not able to be here this evening. But Professor Pepys is and was a world expert in what was thought to be a very rare protein disorder called amyloidosis. And I did my PhD in this disorder, which I completed in 1996. And I basically spent my PhD developing an assay for testing drugs for targeted pharmacological depletion of serum amyloid P component for treatment of human amyloidosis. And it was only a small part of what turned out to be a very big piece of work. And I'd like you to notice that I finished my PhD in 96, and the work was only published in 2002 in the journal Nature, which hopefully you've all heard of, and if you haven't, you jolly well should have done. But it took another 13 years for the human studies to actually be completed, well, just actually to be started. And this is the piece of work that shows that you can actually clear SAP from amyloid. And I'm glad that I had a very, very small piece in this very big piece of work. It took 20 years from when I did my bit to actually getting into the clinic. And this, I think, is a very important lesson in science. It takes years and years of hard slog, and you have to be prepared to stay the game. Professor Pepys also taught me some very important messages. The first is that science is the pursuit of truth. A lot of things are published which are not necessarily entirely true, and it's wrong, and one shouldn't do that. And I'm very proud to say that I have always followed the lessons that Mark taught me, which is to be honest. And if you made a mistake, you go ahead and apologize. And we've done that even a few weeks ago where we had published something which turned out to be wrong, and we had to retract, and that's right. The other thing that he taught me was that the questions we try to answer really must have a clinical relevance. Mark Pepys, I think, was a translational researcher long before everybody else got the hang of what translational research, from bench all the way to the bedside. And the third thing he taught me was we're a small business, and we have inputs and outputs. And anybody's in my lab, please can you tell you, what are the inputs? Anybody's in my lab, what are the inputs? Grants. What are the outputs? Papers, okay? Everybody, that's a mantra. I thought they all knew it. Okay, thank you, Hayley. And I haven't even taught you either. Okay, but I moved from Imperial back to UCL, where I actually studied as a medical student, to work under Professor Stephen Baum. And Steve has been my mentor for the last 20 years. Unfortunately, it's really sad he can't be here with us today. He's roaming through the jungles of Costa Rica, and hopefully he is with us online. Hi, Steve, and welcome. So it was actually not Steve, but Stuart Bloom. Where are you, Stuart? I saw you. There you are. Hi, Stuart. Do you recognise this photograph yourself? Who told me that Steve was looking for a senior lecturer post in the late 1990s, and he encouraged me to apply. So what did I do? I said, what do I know about lasers? So I went to the library. And this actually is a picture of what I always do in a library. But anyway, while I was there, I did learn some stuff, and I'm going to teach you. So the first thing is that lasers have biological effects. And the first biological effect I want to talk about is the effect of heat. So when you have a focused light going into a tissue, that light can heat the tissue up so much that it can actually destroy it completely. And you can use that to destroy tumors. And by the time when I arrived here, that was actually the bulk of our work, was actually laser destruction of esophageal and rectal cancers. You can have a less powerful effect, which causes sealing of blood vessels. And actually, a lot of people don't know this in the room, but Professor Baum was really the person who brought the whole concept of treating gastrointestinal bleeding with endoscopic intervention into the world. And the interventions we use now have come out of the work that he did using lasers to show that you can actually stop GI bleeding. And the third, you can get mild inflammation, or you can just get a gentle wound with no biological effect. So you have a heat effect from lasers, but it turns out there's a cold effect also. And this is when you give patients a drug that sensitizes them to light. And in the presence of oxygen, remember, in the presence of oxygen, you shine the light into the cell, and you get an almost instantaneous effect, production of this highly reactive oxygen species called singlet oxygen, which causes cellular death by necrosis or apoptosis. I don't expect you, the non-medics, to understand all the words, but I just want you to get the general overview and the gist, okay? So you can get cellular toxicity by direct mitochondrial damage, but you can also get a secondary necrotic effect by vascular damage. And so this photodynamic therapy, or PDT for short, is a cold biological laser effect. But there are also non-biological effects. The first one I'm going to talk about briefly is fluorescence. And this is where you shine light of a short wavelength, blue light, into a tissue, and it gets absorbed and then re-emitted as a longer wavelength, red light in this case, but it may be green or red. And it turns out that all of us fluoresce. All living beings fluoresce because we have something called collagen, and collagen is one of these tissues which actually absorbs light and then re-emits it at a longer wavelength. And so we have changes in tissues as they become cancerous. And so you get changes in the autofluorescence. But you can also exaggerate this whole concept of fluorescence by giving a drug. And I'm going to talk about the drug called ALA many times in this lecture. The idea is that you give the patient the drug accumulates particularly in the tumour, you shine your blue light, and out comes a really strong red light signal. So here you can see some very old photographs. This is endoscopy pictures from the late 1990s from somebody in our lab. And you can see this is Barrett's esophagus. Not you can really tell, I'll show you more about it in a minute. But you can see there's red there. And then when you turn on the blue light in the presence of this ALA drug, you see this huge amount of fluorescence in the tumour, which you otherwise wouldn't have seen. There's another effect, which I'm not going to talk about in much detail, although I did a huge amount of work on it, and it's called elastic scattering. And here, white light comes into wherever it is, into your tissue, and the white light gets scattered. And it turns out that it gets scattered depending on the various components of the light, because white light, of course, is the whole spectrum, it's the whole rainbow. And it actually is, blue light is scattered more than red light, and this actually underlies why the sky is blue during the day and why sunsets are red. Let me try doing this. You have the sun in the sky, shining down at an angle. The red light goes off into the stratosphere, but the blue light is shone down onto the ground, and therefore you see the sky as being blue. But at sunset, where the sun is right on the horizon, the red light is only scattered slightly, comes up towards you, and the blue light goes up into the sky, which is why the sky looks very dark blue, but actually the sunset looks red. I hope that made sense, but actually that is elastic scattering spectroscopy, and it turns out that tumours have a different elastic scattering signal to normal tissue. So, in summary, we have treatment effects, hot and cold, and then we have diagnostic modalities using lasers, fluorescence, and elastic scattering. Remember, I was in the library at this point. This is what I found out. I hadn't even started my job yet. So I decided I better go to the job interview with some ideas. And I said, how about patient with suspected early cancer comes to hospital for an endoscopy, and you use a diagnostic laser tool, cancer or precancerous abnormality is found, and instantly you treat it with a therapeutic laser tool. Wouldn't that be amazing, Professor Baum? And what was the response? I got the job. And anyway, I then got to join a very hallowed crew of gastroenterologists. We have here Professor Roger Williams, we have Dr. Martin Sana, and I'm delighted that Adrian Hatfield, who's really been one of my very significant mentors over the years, is here with us today. Thank you for joining us, Adrian. And thank you also to Chris Russell. So, let me tell you a bit about the institution I joined. UCL was the first university in London. Indeed, it was the oldest university in the UK after Oxford and Cambridge. And it was established in 1826. It's now 190 years old. It was inspired by the philosopher and a member of Parliament, Jeremy Bentham, whose concept in life was utilitarianism, the greatest good for the greatest number. And that probably is why this was the first avowedly secular institution, equality for all regardless of race or religion. And I'm very proud that I can now call myself a professor in this institution. And there have been many privileges in my role. First is the wonderful nurses that I work with. For some of you who've not been here for 15 years, you may not recognise Zane. Zane is now one of our senior staff nurses in endoscopy. He doesn't have long hair anymore. And the person on the right, does anybody recognise the person on the right of this picture? Yeah, some of you do. Wonderful trainees. I had the privilege of training Rebecca Fitzgerald, who's now Professor of Gastroenterology in Cambridge, and you'll hear her name come up again through this lecture. So you have to find a niche in life. And it turned out that the United Kingdom is the world centre for esophageal adenocarcinoma, cancer of the esophagus. It is more common here than anywhere else in the world. And when I joined the institution around 2000, it turned out that the rate of esophageal cancer was rising. Okay? That was the USA data. This was the London data. And in the northwest of the United Kingdom was higher, and in Scotland higher still. Glasgow is the world epicentre for esophageal adenocarcinoma. There are two types of esophageal cancer, squamous cell and adeno. I'm only really going to focus on adenocarcinoma, which has been my main focus of work. It turns out, that was the last graph I showed you was sort of finished here. Over the last 10 to 15 years, the rates of adenocarcinoma have risen, but only very slightly. They seem to be plateauing off now. But at the time I arrived, we didn't know that. It was just an ever-rising trend. It's the fourth commonest cause of cancer death in this country. And luckily for us, there is a precancerous abnormality called Barrett's esophagus. So here you can see This is looking down an endoscope into the esophagus. The normal esophagus is coloured pink. It's called a squamous mucosa. And then you have this salmon red area, which is called columnar-lined esophagus, or Barrett's esophagus for short, named after the surgeon called Sir Norman Barrett, who did not work at UCLH. And the problem with Barrett's esophagus is that it can become cancerous. And the biggest problem is that you can't necessarily see the cancer as it's developing. By the way, many of these slides are the original slides that I prepared 10, 15, 20 years ago, which is why some of them are odd colours. And I did that purposely because it reminded me of what I was doing at the time. So, for those people who don't, I'm sorry, it's nice to see people. So, for those of you who don't know much about esophaguses, here we go. The esophagus is a hole for your food to go down. There's your mouth, there's your stomach, and it's a hole, okay? Very simple. That's it longitudinally, and that's it cross-section. Let's get rid of that. It's lined with a mucosa, an inner lining. That's surrounded by a scaffold called the submucosa, and that scaffold is really important because it's what holds this hollow organ together. And then it's got a muscle around the outside called the muscularis. And the muscle contracts and relaxes in order to push the food down into the stomach. So it's not just a hole, it's a sort of a clever hole, if you like. And it turns out that cancer starts in the lining, in the mucosa. And then as it develops, it slowly goes through the wall and then comes out the other side of the esophagus and then starts to invade the surrounding structures. When I first started doing endoscopy, we had fibre optic endoscopes, and this was the sort of quality of picture you could see. It's actually really difficult to see. If I do this, you can just about see that there is the salmon red lining here and a bit of pink there. You can just about see it. In 2001, I managed to get the hospital to agree to buy some new video scopes, and that was the quality of our images there. 10 years later, the quality of the imaging has just improved incredibly. I think you would agree. So here's an interesting question for you. This is using one of our latest generation of endoscopes. There is a cancer in this picture. Is it in area 1, area 2, area 3, or area 4? Okay? Your question, and for those of you who are sitting in front, I suggest you actually move back a row because then you can press the buttons like everybody else does. No, Richard, I really think you should. Okay, 2 Richards in fact. Okay, so where's the cancer? Area 1, area 2, area 3, or 4. Don't do it yet.
Can we have a picture?
Yeah, picture back. Thank you. Okay, you've got 15 seconds, off you go. Press 1 number, and you're only now 1. It won't take your second answer. And don't do too much conferring, because if you do, you won't get the answer. Yeah, okay, you got 7. Some of you haven't answered, I can see on my screen. Thank you. A few more, please. Okay. So half of you thought it was area 3. All right. Hang on. Sorry, technology is very clever, but it's just... So, half you thought it was area 3. If you look in a bit more detail, you can see that the lining here, this is actually normal. This just doesn't look quite right, and the vascular pattern here doesn't look quite right. And when you use this, what's called the iScan 3 mode, you can actually see this whole area just looks a bit abnormal. So even a non-expert can start to see cancer now. You don't need people like me. Turns out you do, as it happens, but I won't show you the data. We've done some work to show you really still do need experts, which is quite reassuring. The 10% rule in esophageal cancer. 10% of the population have acid reflux. 10% of them get Barrett's esophagus, which appears to be a way of reducing the discomfort, the heartburn, the chest pain, the symptoms of acid reflux. And of those 600,000 patients in the UK at the moment with Barrett's esophagus, we only know about 1/10 of them. We don't know most of these people. Most of them never come to a doctor. And 1/10 of them will eventually get esophageal cancer. So we have 1/10 of people with Barrett's esophagus getting esophageal cancer, but unfortunately we don't know who most of those people are because they never come to a doctor. That's a bit of a problem, which we'll come to later on. Barrett's esophagus. Here you can see the normal pink lining of your esophagus and the red Barrett's. You should be getting used to this now. These are some pretty nasty early lesions, which are early cancers. And there is a variable progression from squamous mucosa, which is normal, it's SQ, through non-dysplastic Barrett's esophagus, through low-grade dysplasia, that's dysplasia means badly formed cells, through high-grade dysplasia, and all the way to esophageal adenocarcinoma or cancer. 10% of the patients with heartburn get Barrett's, but the risk of moving from Barrett's to cancer is actually low, and the vast majority of patients with Barrett's esophagus will never get cancer. And so we have a conundrum. We don't know who they all are. We know that if we find somebody, we don't know if they're going to get cancer, but if they do get cancer, it's going to be fatal. When I arrived here in 1999, it was a 5% 5-year survival. It's gone up significantly over the years, but it was pretty awful then. So at that time, there was no screening test for Barrett's esophagus. And if you had Barrett's, or if you had low-grade dysplasia, and indeed, even if you had high-grade dysplasia, most people would go into regular endoscopic surveillance if they were prepared to have it, and most people didn't like doing it. For people who had cancer, only people with early cancer, or people, some of the people with high-grade dysplasia, depending on how progressive your surgeon was, would do surgery, and then the rest of them, unfortunately, would be palliated and eventually die. Esophagectomy surgery, at that time, it's much better now, but at that time, over 5% of people would die, and in some institutions, up to 20% of people would die just as a result of surgery. Not in this institution, but in some institutions it was like that. This institution actually didn't do surgery, but we'll talk about that another time. Early complications, up to 40%. There was a risk of recurrence. The patients were elderly. The average age at which esophageal cancer is diagnosed is around 70. So there was a need for something minimally invasive if people could think of it. So you really don't want to take out the whole esophagus when actually all the problem is limited to the inner lining. Could you do something just to treat the inner lining? So this is the same thing, just turned on its side. So here we've got our mucosa, there's our submucosa, and there's our muscularis. And what we're really talking about is what we call high-grade dysplasia, where everything's limited to the mucosa. Is this curable with endoscopic therapy? So remember, we've talked about laser effects. There's hot and cold. Photodynamic therapy is where we're at. In 1995, just as I was finishing my PhD, Professor Baum published this paper, and then the year later he published this paper. And these papers showed the proof of principle that ALA, 5-aminolavulinic acid, could be used to treat esophageal cancer, or pre-cancer, I should say. By the time I arrived here, there were 6 patients waiting to be treated. They'd found the papers and they came and asked for treatment. And the treatment's simple. You do your endoscopy, you then put this little balloon down the endoscope, not down the endoscope, down the esophagus, you blow it up, put your light source, your laser light source inside, having given the patient the drug, turn it on, and the patient is cured. Here's some nice pictures. Prior to therapy, a day after the treatment, you can see the whole of the inner lining has been necrosed, it looks horrible. A month afterwards, it's all healed. And if you're lucky, the Barrett's esophagus has all gone away. It doesn't always happen that way. These are nice pictures, so I'm showing them to you. 90-year-old man, he had a very early cancer of the stomach. This is actually the top of the stomach. We gave him photodynamic therapy into the tumor. 3 days later, the cancer's all disappearing. 2 months later, it's healed. So it did work. We saw cases where it worked. Okay, here we go. This is really important. If you were a doctor with a 72-year-old patient who has a high risk of getting a fatal cancer, and the only proven therapy is surgery, and you're an enlightened surgeon, and the surgery has a high cure rate, but 1 in 20 chance of killing the patient, would you recommend they try an experimental therapy which has unknown side effects and which might not work at all? Okay? You're the doctor, you're the surgeon. Would you operate, or would you tell the patient to have a completely experimental, untried treatment? This is an important question, and it was really relevant. You've got 15 seconds. Can you answer 1 or 2, please? On your keypads, for people who arrived late, there's a keypad in front of you, press it. So, most of you think the surgeon would say, try the experimental therapy. So that's really interesting. The reality was completely different. So I'm not sure that you really need to see the next question. Because the next question is, it hasn't got a number. If you're a 72-year-old patient and you did not have cancer and you were told that surgery had a 1 in 20 chance of killing you, would you be prepared to try a minimally invasive experimental therapy, which might not work and would allow you to have surgery later on? Yeah, I'd try it, is number 1. No, I would not, is number 2. Okay, 15 seconds, and go. And it's exactly the same, which just shows you that this doesn't really work. So the reality was that the majority of surgeons would not allow their patients to go for this treatment. They wanted proven therapy. And if I were a surgeon, I think I would want that too. I want to have some sort of certainty for my patient. And what actually ended up happening was the average age of the patients who came to our program was 80 and over. And we dealt with a lot of very old people, which turns out not necessarily to be a bad thing. So we were going to give them a drug for this PDT treatment. And it turns out there were two drugs available. One was called Photofrin, and the other one was called ALA. And I'm going to take you through this picture. This is a rat stomach. That is the mucosa, the inner lining. There's the submucosa, and there is the muscularis. This blue shows where the photodynamic drug is taken up. Photofrin is taken up into the submucosa, the scaffold, whereas ALA is taken up into the mucosa. ALA should be a better drug, because that's what you're trying to treat. You're trying to treat the inner lining. Tantalizing information. These were published papers from other groups. Photofrin, 100 patients were treated. 78% of them had cure of their dysplasia. Unfortunately, a quarter of them developed strictures, narrowing of the esophagus, which was really problematic to treat. And because the Photofrin stayed in the system for 3 months, a third of them got sunburn, and sometimes it was pretty nasty. ALA, on the other hand, data from 66 patients, had an 89% clearance of high-grade dysplasia, no strictures, no sunburn. Sounds good, right? Oh, here we go. Hang on. Where is it? I've been told to be really careful with these. Right, now. This is a green laser pointer. Everybody happy? I mustn't shine this at you because it's so powerful I can actually blind you. So please don't look at the laser pointer. If I by accident do shine at you, please don't look at it. Green laser pointer, all right? Green turns out to be absorbed by tissue much more easily than red. Red penetrates, as I shall show you. Green laser pointer, my finger. You can't see it. Okay? Can't see, you can just about see a bit of green. Red laser pointer, okay? Same power. Ooh, isn't it nice? Okay, so I got a question for you. Which colour light would you expect to work better to cure mucosal disease, which is 500 microns? It's 0.5 millimeter thick, okay? The one where all the light is absorbed into the mucosa, or the one where the light gets transmitted through. Green light or red light? So you've got to give me the answer. Hang on, where am I? Here we are. Green light or red light, go. You've got 15 seconds from now. Number 1 for green, number 2 for red. Which one's going to be more successful in therapy? And the answer is, you all thought green light. That's what we thought. Turned out to be completely wrong. Actually, every single patient we treated with green light, we had to retreat. So that wasn't any good. We treated 72 patients over some years to actually identify what the ideal treatment parameters were. And we started with green light, gave up very quickly and moved to red light. And it turned out it wasn't only the colour of the light, but it was also the dose of drug, 30 milligrams per kilogram or 60 milligrams per kilogram, and the amount of light, the duration of time that you treated them. And we did actually get a treatment which looked like it was going to be very, very good. In the meantime, other people were working on this other drug, Photofrin, and they showed that compared to no treatment at all, people with Photofrin had a 50% likelihood of having their high-grade dysplasia reversed. So in this graph, being down here is pretty awful, and being up there is okay. Not brilliant, because you like people to stay up here, but anyway, they weren't. But they got 25% of them got strictures, which meant they couldn't eat properly, and it was a bit of a problem. And they showed that the cancer risk halved. So the 42% cancer risk at 5 years if they weren't treated, was a 22% cancer risk at 5 years if they were treated. So you halve the cancer risk, which is, it's creditable. It's not brilliant. It's okay. We showed, with our 72 patients, that with our highest drug and light dose, we were fantastic. It's absolutely amazing. 78% clearance of high-grade dysplasia at 4 years, 97% free of cancer at 4 years. Who wants the drug? At this time, the peer review came along to check. I had to build a whole service. There was nothing here. We had 6 patients when I arrived, and we then got up to seeing 50 or 60 new patients a year. And in the last few years, we've been up to 100 new patients coming through every year. And we were told, high-quality diagnostic interventional service, excellent diagnostic interventional facilities available, provided by internationally renowned clinicians, I don't know who they were, exceptional leadership, provided by the clinical lead, but the lack of surgical coordination limited progress. And we had a problem that surgery was not happening at this institution. And then there's actually been a 10-year process, and now I'm pleased to say that the entire esophageal cancer gamut of work happens all at UCL, UCH. And I think that's, our work has been a small cog in that rather big wheel. But it was very important. And in fact, we even got into the Daily Mail, which means that we really made it. I quite like the bit at the bottom. I've always had troubles with my digestion, and I tackle it with colonic irrigation, but actually that's nothing to do with what we were doing. So we treated our 72 patients. Unfortunately, it wasn't quite plain sailing. 4 patients had severe drop in their blood pressure, which lasted for hours after the drug was given. And we learned how to prevent it. You gave them lots and lots of fluid beforehand, and you had to stop giving them psychotropic drugs. We had somebody who was schizophrenic, and we discovered that was a really bad thing. 3 patients had aspiration pneumonia, and sadly 1 patient did die. But he had cirrhosis, and he knew the risk, and there was no other option for him. And it was one of those very sad things, but it happened. So eventually, PDT for Barrett's esophagus gets approved. But in fact, other centres used our same drug, ALA, and they did it as an outpatient. In Harvard, 1 death in a patient who collapsed and died at home 24 hours after treatment. In Amsterdam, a patient actually died in the hospital car park. That was pretty awful. He walked out after treatment and just dropped dead. And the PDT programs using the drug ALA were stopped in those locations. So we actually have a really important question now. We seem to have some really good data suggesting that ALA was good. Is it better or worse than photofrin? Does it have less or more side effects than photofrin? So we did a randomized controlled trial comparing the 2 drugs. We decided to do it just at UCLH because actually nobody else in the country was doing this sort of work. And it took us 3 years to recruit our 66 patients. And as you can see from the graph, low blood pressure, pleural effusions, nausea and vomiting, chest pain, aspirations, very similar between ALA in orange and photofrin in blue, but stricture formation far less in the ALA, although there were some, and photosensitivity, skin sensitivity, like you can see here, far, far, far less. So we did the randomized control trial, and this is why you do randomized control trials. Anybody understand what this shows? It shows that there is absolutely no difference between photofrin and ALA, and what's more, they're both useless. They're both terrible drugs, and it was really very upsetting. However, we compared the long segment Barrett's, which was more than 6 centimetres, where they were both pretty awful, compared to short segments, less than 6 centimetres, which you could do with 1 single balloon. And it turned out the ALA was actually significantly better than the photofrin for short segment Barrett's esophagus. But anyway, 10 years of work, ALA, PDT, it's not as good as we thought. It's not better than photofrin, has some nasty side effects. And that was pretty miserable. So let me tell you about a 78-year-old man who had high-grade dysplasia in Barrett's esophagus. He was admitted to hospital for PDT in 2008. The treatment went like a dream, absolutely fine. Ladies and gentlemen, just take a breath. He died 5 days later, 2 days after discharge, and the cause of death was Clostridium difficile diarrhea. And that was completely and utterly unexpected. We just weren't, we had no idea. He went out of hospital completely well. C. difficile is a major cause of hospital-acquired infections. It was first described in the 1970s. By the 1990s, there were 1,000 cases coming, and it suddenly just took off. In the mid-2000s, it was absolutely mad. We had almost 4,000 deaths in the UK in 2005. And we started doing some work just after our patient died because we were so bothered by it, and we were very grateful for the funding we received. I'm not sure I'm allowed to mention who the funders were, but thank you to the funders who are sitting in the audience. Hypervirulent strains of C. difficile we looked at, and we used our PDT approach. Light plus photosensitizer plus oxygen causes cell toxicity. And when you're using it with bacteria, we called it packed photochemical, oh dear, I'm sorry, I shouldn't have said this, photochemical antimicrobial chemotherapy. We had to use a different name because, it's something new. And it turns out that PACT has been used in many different areas, acne, dental infections, wound and burn infections, and disinfection of medical devices even. And it does have some traction. We designed it. for use in the colon. Remember I told you that PTT requires oxygen, and there isn't very much oxygen inside your colon. It turns out there were a whole series of photosensitizers, PS, which do kill C. difficile in anaerobic conditions without oxygen. And we then went on to show that not only does it work with bacteria grown on the plate, but actually if you grow them in colonies, which is more like how they grow inside your gut, in the presence of light, you don't get any death at all. When you add methylene blue, which is the photosensitizer, you get a bit of death, so non-specifically, both in planktonic bacteria and colonies. But when you add the light, both in the plankton, I know what's coming next, both in the planktonic and the colonies, you get complete kill, which is very, very exciting. Luckily, however, for patients, the strict hand-washing routines that were introduced by UCLH and other hospitals reduced dramatically the incidence of Clostridium difficile diarrhea, and a new therapy came along which was 90% successful or more, and suddenly it becomes less important to do what we were doing. And this was called fecal transplant. Fecal transplant means taking somebody else's poo and eating it. And so if somebody told you that in order to save your life, you had to drink your next door neighbour's feces, would you? This is actually very, very serious. I mean, it sounds like a joke, doesn't it? It's actually serious questions. Would you A, jump at the chance, B, go and vomit and then just get on with it, or C, accept that your time is up and under no circumstances are you going to drink somebody else's poo? You have got 15 seconds to answer the question. And here is the point, that no new medical intervention will be taken up by everybody. Usually you get about 50%. Usually even the colon cancer screening in the United Kingdom, which is proven to save lives, and those of you who are over the age of 50, I won't ask you to put your hands up, but those of you who've already done it, you smear the poo on the stool, on the card, and you send it back, and they tell you need a colonoscopy, and then you're cured from your colon cancer. It works, but actually no more than half the population will do it, because actually people are frightened of those sorts of things. And there you go. You're just a particularly keen audience, I think. So this is one of the things that people told me, was that doing research was like being under a dark cloud. And you spend most of your life under a dark cloud, but then every so often there's a ray of sunlight that comes through. And so let me just tell you about a couple of rays of sunlight, or this one. Edward had early esophageal cancer, treated with radiotherapy in 2004. Unfortunately, it failed to eradicate his cancer and it came back. He was offered photodynamic therapy in 2006, which I did, and which eradicated his cancer. He never got it back again. Unfortunately, it caused an intractable esophageal stricture so bad that this guy lost huge amounts of weight, was unable to eat properly. And I couldn't do anything to help him. I tried dilating, etc., etc. I sent him to Ed Townsend, who was a fantastic thoracic surgeon at Hereford, who was just about to retire, who said, "You're not fit for surgery." All the reasons there. Ed Townsend suggested self-dilatation, getting the patient to swallow a dilator every day. It's a very old technique. We don't do it very often anymore. It fell out of fashion 30 years ago when endoscopic therapy became possible. Edward did this, and he was able to eat normally for the rest of his life. Sadly, he passed away 4 months ago from other causes, but he lived for 10 years after his esophageal cancer was treated. And we have used what we learned from that one patient to successfully teach other patients. And we have 30 other patients with various other benign esophageal problems who are using self-dilatation now, having been something that had been more or less forgotten from the medical armamentarium. So, flashes of light, it's great when they happen. So, photodynamic therapy, what's going to happen here? I know what's going to happen here. No idea. Oh yes, I remember. Photodynamic therapy was out. Photodynamic therapy was out, but luckily there was a new treatment. And this one was using heat. It wasn't laser, but it was heat. And it's called radiofrequency ablation. And basically here, it's like the heated rear window of your car. You can sort of see the lines on the screen, and they're basically just heat. And the heat gets passed from one to the next, and you get a precise burn 1/2 of 1 millimeter deep. And it's quite amazing. And it was revolutionary. Because what happens is that you put your little balloon down the esophagus, you blow it up, and it takes 1 second, and you've basically burnt the inner lining of the esophagus, which is all we want to treat in this disease. And it doesn't hurt, Caroline, it's okay. And then you do it to the next area, and then you're done. And the whole thing doesn't take very long. So here's some pictures, just to show you what it looks like. There's a normal esophagus, or your Barrett's esophagus. There's the balloon going down, and that's after treatment. This was work from Nick Shaheen, who works in North Carolina and is a good colleague of ours and a collaborator. And I just point out, just over here, compared to no treatment, patients who had complete eradication of this, who had the radiofrequency ablation, the RFA, had an 81% success rate. You might ask why these people had any success at all, and that is because these precancerous conditions are not quite so straightforward, and sometimes they actually just regress spontaneously. In any case, the risk of adverse events was almost zero. There's virtually no esophageal stricturing, our big problem, and there was no sensitivity to light. And follow-up data suggested that these patients, once cured, remained free of their disease for long periods of time. There was another technique that came along at the same time called endoscopic mucosal resection. Here's a little nodule. This actually carries a small cancer. What we do is we suck it up inside this little cap, and then we chop it off, and you end up with a hole. Luckily, that hole doesn't go all the way through the wall of the esophagus. If it does, you kill the patient, but we don't do that. So that's good news. And then you end up with this really nice piece of tumour, which you can send off to the pathologist. Now, pathologists like this because they can tell exactly how big the abnormality is and how deep it extends and how likely you are to have cured the patient. So the technique, I'm just going to tell you very briefly, is you inject some liquid underneath. This is actually a colonic polyp. You inject the liquid, you can see the thing lifts up, and then you chop it off. Just remember that for later on. So most of the work on EMR was done in Wiesbaden in Germany, and the question we had was because after EMR alone you get recurrence of the problem, could you combine EMR with radiofrequency ablation? And we set up the United Kingdom RFA registry in 2009, and it started off with a few centres. It grew, and it's now got 28 centres around the country, all cancer centres offering this treatment to their patients, and I'm very proud that we still lead this group of this group of doctors in helping what is now thousands of patients around the country. And actually this work led to publications, and just in case anybody's interested, my middle name really is Bruce. I thank my mother for that. Our 12-month outcomes turned out to be better than the randomized control trial. 87% complete eradication of high-grade dysplasia. Only 81% in their trial. And we then discovered that the longer the Barrett segment, the more times you had to treat them in order to cure them. Okay, we're learning. And we've learned a lot of things. The predicted durability actually has been pretty good. And it's getting better. And the treatment's getting easier. And we're actually rather proud of what we're doing. The cumulative cancer risk is actually extremely low with this treatment. There's an 80% reduction in cancer compared to historical controls. Esophagectomy is avoided. We've actually changed what goes on. And I have to tell you, before I show you this 2013 British Society of Gastroenterology guidelines, let me just tell you, in 2012, I stood in a room like this in front of the leading surgeons in this country, and I showed them these data, and they said to me, you're wrong, you mustn't do this, patients should have surgery. In 2013, the British Society of Gastroenterology came out with guidelines saying they should have endoscopic therapy, and that was the end of the story because no patient ever got in front of a surgeon again. And that was really interesting because actually it turns out that the people who make the decisions are the people who the patient gets in front of. And if the surgeon's the person you get in front of, you're going to get surgery, and if you go in front of a physician, you get medicines. And this is important, and I have to be a bit careful because it sounds like I'm dissing surgery. I'm not. I'm just saying that you have to be very careful in how you make your decisions. And we're doing radiofrequency ablation all over the case. Now watch this. Another treatment modality called APC, argon plasma coagulation. You simply fire a little beam, and it just zips the tissue. APC is a cheap, rough and ready technique. And I didn't like this study. Feasibility study comparing APC with RFA. RFA I spent 10 years on. It's brilliant. It's so easy. And we did this study because we thought we'd better be in it. It was actually led by John DeCastica from somewhere in the Midlands. That's terrible. John, sorry. And I can't remember. Leicester, that's it, Leicester. It's outside London anyway. And we were one of the centres in this feasibility study. It was actually quite hard, like all studies. You take 170 patients, you screen them, and actually less than half of them get into your study for all sorts of reasons. But look at the outcomes. If you had short segment Barrett's esophagus, whether it was with RFA or APC, pretty much all of them get cured. If it's slightly longer, 80% is not as good as our data from RFA, but it's pretty good. There aren't enough patients with the long segments to make any comments. But look at this. What's the most striking thing you see here? The difference in cost. APC costs £3,000 or £4,000 per patient, and RFA costs £25,000 per patient. APC might just be as good as RFA and very much cheaper. Okay, here's a question for you. You are the chairman of UCLH NHS Foundation Trust. Thank you very much for being with us. Would you like us to move to use the cheaper treatment? Yes, I've shown you that APC is pretty good. I'd like you to move now to the cheaper treatment. No, actually, it's not necessarily quite as good. RFA, we're up to 90-95% success rate, and this is only 80%. Do we care about that 10% increase in benefit? So we shouldn't move there, or perhaps we need to do some more research. You have got 15 seconds to make your minds up. Go. Oh no, don't go. Wait a minute. Oh, something's not working. Oh, it's not working, guys. Try again. No. Oh, hang on. Oh, wait a minute. What's happened here? No. I've lost it. Oh, well, hands up. Old-fashioned. Who thinks we should move to new treatment? Yeah, it doesn't matter, it's up there, it's not working. Who's new treatment now? A couple. Who thinks we should stay with the old treatment? Who thinks we need more research? The bad news is there's no money, guys. Okay? It costs millions of pounds. To do that piece of research you want will cost the NHS millions. Okay? Maybe we should do it, but it's going to cost millions. Okay, next question. Should we be treating these patients at all? Margaret's story. She first came to us in 1999. She was aged 83. She was a spinster living in Whitstable in Kent with a 2-hour journey to London. She lectured on the history of British pub names. She went around Kent lecturing. She really did. And she had high-grade dysplasia in Barrett's esophagus. We treated her in 1999. We successfully reversed her dysplasia, her precancerous changes. She had residual Barrett's, and sadly, 5 years later, she got cancer. By that time, we were doing endoscopic resection, and we successfully eradicated it. 4 years later, she got cancer again, and this time we did the EMR plus radiofrequency ablation. In 2009, when she was starting to become demented, we did just a routine endoscopy, check everything was all right, and she had serious complications. We had to keep her in hospital for 3 days, and we said, whoa, you are too old and too frail to have any more endoscopy. We're not doing any more. Margaret died in 2011 with dementia at the age of 95. What did I achieve for her? I just struggled for years to think, was I doing her a good turn or not? 2 years before she died, she sent me this Christmas card. To Dr. Lovat and family, thank you for the years I did not think I would see. And that for me was the ray of sunshine. Okay, ladies and gentlemen, it's getting late. I want to tell you about this stuff, but I'm not going to. I'm going to have to move on. Where are we in 2016? So surgery was all across here. We've now replaced part of surgery. Surgery still has a very important place of people with cancer, but we've now moved into the EMR RFA era. Surveillance, we've done some work on that, but I'm not going to talk about that. I want to point out that we recruit large numbers of patients to trials. I'm sorry, I didn't actually update this. This only goes to February 2020, but it goes shooting up. We recruit about 500 patients a year. Professor Emberton and I actually have a little bit of a nice combat about who recruits more patients to studies. Between us, we actually recruit far more than the rest of all the other clinicians in University College Hospital at all. No, I thought I'd just tell you that. Anyway, So I was invited to be an international guest lecturer at the International... Oh, come on. What's going on here? International Photodynamic Therapy Conference in Israel in 2009. They said to me, please talk about PDT for cancer. I said, I know about PDT for Barrett's esophagus. They said, no, we've got that covered, which wasn't very helpful because I didn't know anything about cancer. So I sort of did a quick run around UCL, and I met Professor Kerry Chester, who was an amazing scientist. And she taught me about targeted photodynamic therapy, where instead of the drug going all the way around the body, you target it to where you're interested in, and it just goes to that one place. And in theory, you get a whole series of benefits by targeted PDT. And I thought to myself, hang on a minute, if you applied this to the esophagus, you could simply put your laser all the way down the esophagus, and the red light will go out through the wall of the esophagus to the surrounding lymph glands, and actually you could do what the surgeon does. The surgeon, after all, just removes that whole area. We could do it endoscopically and get rid of even more surgery. We teamed up with our friends at Anticore. Thank you for being here, Dino. Yeah. And we got a grant for Innovate UK. This is £1 million. And what we did, or what they did, was they chopped off a little bit of the top of an antibody called a short-chain variable fragment, and they linked it with their special OptiLink to allow us to put a whole load of drugs, of photodynamic therapy drugs, onto a single little target. And what you end up with is this amazing, he says, I can't get my, oh, there we are, this amazing little drug, which has more drugs on it, and is more targeted to where you want to go. So you have a real bang for your buck. And we were able to show that this was actually taken up into the cells, which is where we want it to be. And we decided for various reasons to select a particular target called HER2, which many of you will have heard of as being upregulated in cancer. It's only about 25% of esophageal cancers, but it's a proof of principle. We created this brand new drug, which was targeted at the area we were interested in, and we then developed tumours in little rats. And this is a tumour which we developed in the flank of a rat. This is actually a human esophageal tumour, which is sitting in a rat flank. And then, we put some cells in, and it grows like bilio. It's amazing. And then we treated the poor little rats. We just shine light at the tumours. And at the very end of this project, which finished last October, we showed this presentation. I'm very, very, very interested to see what you think of this slide. So we said, we're part way through the experiment. We're treating today with dose 4, and we'll come back to you in a couple of months' time. We actually ran out of money, and I had to find some money, and I kept the people on for 2 months. Thanks so much, team. Where are you? Team? You there, Hayley? I can't, whatever. Where's Laura? Oh, Laura, you're there. Fantastic. Thank you for being here. What happened? We extended the project Christmas, and actually it worked. And actually we were really excited. We've got, apparently, a drug that will certainly hold the esophageal tumour and stop it growing. Whether it is enough, we think we know what to do next, but again, it's another £1 million needed. Anybody's got some spare cash, we're very interested to talk to you afterwards. We might have a new treatment for esophageal cancer, and it might just work inside the esophagus. And what we did as a final little thing of this project is we actually created a new esophageal tumour model. Unfortunately, when I put the videos in to show you that these rat endoscopies that we were doing, unfortunately it crashed my system this morning, so I had to take the videos out. But if you can imagine, remember we were talking about EMR before? This is a rat esophagus, and we're putting the needle in. As we would do with the EMR, we're injecting the cells, and you can sort of see the tumour cells being injected there. And we then did whole body bioluminescence imaging, and you can see the tumour growing over a couple of weeks there. That's it in numbers. We ran out of time, ran out of funding, and we can't get more funding for it. It's another $1 million we need. So where should we go now? I'm going to finish in a minute, but I just got to tell you about this. And that is screening. So many of you know that most people present to the doctor with symptoms, and it's usually too late to cure them when they've got symptoms. Professor Rebecca Fitzgerald, remember? I taught her, but she's actually now the world leader in this area. She came up with a brilliant idea, capsule on a string. We recruited more than 450 patients to one of these studies with her. So here's the capsule, you swallow it, it's on a string, and then when it's in your stomach, the capsule sort of disintegrates, and out pops a sponge, and you just pull it back out through your mouth. Who in the room has actually used the cytosponge? We've got a couple. Okay, I won't ask you, but I know that many people did not like the cytosponge. They found it thoroughly unpleasant. I use the cytosponge. Oh, sorry, I forgot to put my pen up. I use it too, and I found it thoroughly revolting. And that's a problem because you want people to do your test. It's brilliant. It's really good at detecting precancerous changes in the esophagus. But we hypothesise something slightly different. What puts an individual at risk? Well, it's your genetics, it's your environment, and it's the diseases that you've had over the years. Can we detect your risk just by genetic analysis or using big data and artificial intelligence analysis? And it turns out that there's a whole new field starting to develop around salivary diagnostics. Saliva is the mirror on the body, and biomarkers are actually available for us in the saliva, and they've been shown to be valuable in cardiovascular, kidney disease, diabetes, and cancer. So we asked, could we accurately identify individuals with or at risk of esophageal cancer simply using questions, or integrating with salivary transcriptomic data. That's the next step on from genomics, and I'm not going to spend too much time explaining it to you. What we did was we took loads of patients attending UCLH, who had some hundreds, patients who come from their GPs with suspected cancer who don't have it, patients with Barrett's esophagus, with all the way through to cancer. We asked them loads and loads of questions, and we took a 1 ml saliva sample. And we had 204 questions actually asked, and then we teamed up with a rather clever guy in Jerusalem College of Technology, Professor Rosenfeld. Oh, by the way, hi Avi, I think he's online. Analysed using novel artificial intelligence techniques, and he did create some completely new techniques to do this work. And it turns out, just using questionnaires, you can get an accuracy for detecting who's at risk of 80+%, which is not bad. It's not brilliant, but it's not bad. But we then added in the salivary diagnostics. We took 20 people from all of these 4 categories: normal, Barrett's, high-grade dysplasia, cancer. We took the saliva, and we did all sorts of clever stuff to it. And we didn't have any money. So all we did is we guessed which genes might be interesting. We guessed on 13 genes with 22 targets within the genes. And we then ran some beautiful stuff in the lab. Don't ask me, I don't really understand all this stuff, but the people who do will be embarrassed if I try and say the words, so I won't. So thank you to everybody who does this, by the way. So here you can see the normal person, the person with Barrett's, and the person with high-grade dysplasia. And these shifts don't look very big, but actually each of these shifts is about a 10 times higher expression of the particular gene of the RNA amplicon in focus. And you can see the same gene that I just showed you there. Big difference between normals all the way through to cancer. And different genes have different expression levels from normal to cancer. And if you start putting these together, it turns out that 6 of them, plus 5 questions, could identify patients at risk with now an accuracy of almost 90%. And this is only the beginning. We're moving on to we've now got funding, I'm glad to say. And again, thank you to the funders who are in the audience. We are now doing whole mRNA sequencing and epigenetics, and I can't tell you about the data yet, but I have to say they're looking pretty exciting. And we're now going to validate our findings from 300 patients from UCLH we've already collected, with hundreds of patients from independent hospitals. And ladies and gentlemen, I think that we are potentially on the verge of something completely novel, because if this works, it will work not only in esophageal cancer, but also in every other cancer. Before I tell you about the future, I just want to say a great thank you to the team members. We only work like we do because of the teams. And there are loads and loads and loads of people I need to thank. So I'm not going to do that here, but consider yourselves all thanked. And I also have to thank the vast numbers of funding bodies who have funded us over the years. We've received funding from every single one of these bodies, and we're very grateful to all of them. The future. I've told you what sounds like I'm trying to get rid of surgery. Actually, I'm not. I'm trying to hone surgery so that it's used in a more precise, more focused way, better for patients. And I'm delighted, Professor Emberton, to show you the first graphic for our new Charles Bell House, the Wellcome Trust EPSRC Centre. It might be. We have a £12 million bid in for this, for surgical interventional sciences, but the actual building is going to be ready next year. £17 million is being spent on this, and it's bringing engineers and interventionists together. Professor Modera has given me the great honour of being the deputy director, because Professor Emberton is the medical director of this. I'm the deputy medical director of this new venture. It's being led by Professor Orselin in engineering, and I think it's going to be incredibly exciting coming together of the engineers and the doctors to try and hone and improve what we do. So the future, I actually think that salivary diagnostics work really could go places, and I want to extend it to other cancers. So if you had a vague swallowing discomfort swallowing, and your GP told you could either have a large tube shoved down your throat or take a small sample of saliva to see what was wrong, which test do you prefer? You're going to have to get your hands up. Number 1, enormous tube, which would make me choke. Or 2, a little sample of saliva, which I just spit in the pot. Hands up for number 1. Idiots. Hands up for number 2. Oh, good. I'm so glad. Since most of you prefer to do a saliva test, would you agree that there is a research priority to develop such a test? Number 1, I agree it's a research priority. No, I'd rather just put up with a big fat tube down my gullet when the time comes. Hands up for number 1. Good. We won't ask for number 2. With that in mind, I have some helpers in the room. Would the helpers please like to start their work? We're very grateful that you think that this is a research priority, because actually we need some help in our research. It turns out that we need some completely normal people to give us some saliva. And so we will be handing round these saliva pots just now. Could I have one here, actually, please? And I just need to show you what to do. Can I just take one, please? Roisin, can you just give me one, please? Okay, that's fantastic. So, ladies and gentlemen, you probably know that when you're in the medical field, you really have to just accept that things aren't always quite as comfortable as you'd like them to be. When you're in front of the doctor, what you do... Oh, excuse me. About 10 will do, I think. Okay. I'm running out of saliva. I think it's probably 2. And then what you do is you put the lid on, and then you shake it, and make sure it's really well mixed with the preservative. It's got to be mixed with the preservative. If it's not, you're in trouble. So make sure you have a really good mix of preservative. Give it sort of good 10 goes. Okay. Pass them around. While you're doing that, I'd just like to say thank you to the vast numbers of people who have helped us do this work. There is no way that I could have got to where I've got to without the help from all these numbers of people. It's just phenomenal. Thank you very much indeed. And before I finish, you need also to fill in the sheet of paper that's in your envelopes, whether or not you give saliva. And there are pens coming around for anybody who needs them. We have thought of everything today.
So I wonder if I could just stop you from spitting just for a moment and congratulate Professor Lovat on a truly wonderful inaugural lecture. I think you enjoyed that. Yeah. And I think we would better arrange a part B so you can get all the slides in that you chose to.
Thank you very much. But I seriously would like people to spit and to return the pots to us. It wasn't a joke. It might feel like a joke, but it wasn't.
So this is a world first, I think. So audience participation, self-experimentation on your finger, and then a clinical trial without consent.
And as you will see, I've very carefully written, I'm happy to be contacted for formal ethical approval when I use my saliva in the study. I understand saliva I donate today will not be used for anything unless I sign informed consent under an ethically approved study at a later date.
Great.
Okay? Really good.
The Royal Institution looking for a Christmas lecturer this year, so you made the approach. So I just want to finish on a personal note. Right at the beginning, Laurence talked about inputs and outputs. And we've heard about a lot of the outputs, but his modesty hasn't allowed him to share all of them. I've had the great privilege and pleasure of working with Laurence for many, many years now, in many ways actually, and it's been a real privilege to work with you. And over the last few years we've worked together on some really difficult things, and Laurence is one of the people in the team that doesn't shy away from these difficult problems. He addresses them, and he does so willingly and happily because of the greater good. And when you're working next to Laurence, as you've seen today, that sense of wonder never disappears. And as scientists, it's that sense of wonder that we have to keep glowing. And working with Laurence, you have it all the time. So it really has been a privilege and pleasure. This is a thoroughly deserved professorship. And you've done us proud by giving us a truly, truly wonderful inaugural lecture. Thank you very much.
Thank you.